Thank you so much for having me today. It's a pleasure to be here. I'll be discussing the con side of the targeted temperature management approach debate. My name is Matt Siuba. I'm an intensivist at the Cleveland Clinic in Cleveland, Ohio. I have no conflicts of interest related to this talk. The objectives today are to review pertinent literature on targeted temperature management after cardiac arrest, and more importantly, perhaps, to describe how the environment of TTM may affect processes of care. To date, the most effective use of targeted temperature management I've seen was in the movie Black Panther, but remember that T'Challa also received the heart-shaped herb, which I believe at the time of recording of this talk is not FDA approved. As with any other targeted temperature management debate, we'll start with the Bernard trial, and actually I think I'd rather just skip it because this is a really small, unblinded, and only quasi-randomized study. It probably really doesn't even merit our attention, except that it's a precedent for the way that we do things currently. Now is a good time to also mention that I link to any pertinent studies as a QR code in the bottom corner of the screen, so if you want to read more about these items, you can take out your phone, take a picture of that, and go to the link. We can now turn our attention to the HACA trial, which is a truly randomized study that assessed this question. Really impressive reduction in mortality, 14%, which perhaps is implausible, and here we're comparing 32 to 34 degrees versus normothermia, which was not a tightly regulated normothermia, and in fact here in the comparison between the two groups, you can see that the temperatures were approaching 38 in some instances in the quote-unquote normothermia group. As happens in critical care, then we take these small studies and a decade goes by and we've changed our practice and scores of patients are receiving targeted temperature management down to 32 to 34, early goal-directed therapy thanks to the Rivers trial, and even some Xigris while we're at it. Then we're fortunate to enter the age of the modern clinical trial for targeted temperature management, where we have large multi-center studies with blinded assessors and active control groups. And by active control groups, I mean we're truly striving towards normothermia somewhere between 36 and 37 degrees Celsius in most cases. The three main trials which we'll talk about today are the TTM trial, Hyperion, and TTM2. The TTM trial was really encouraging because we finally now have a study with a large group of patients, 939 who were randomized and assessed out of hospital cardiac arrest, 33 versus 36 degrees. And again, this is an active management of 36 degrees to avoid fevers. And here's the differences in the temperature curves shown here in this graph. But in this case, we see no detectable benefit for neurofunction or survival, which I'll show on the next slide. So this really calls into question the decade-plus practice of 32 to 34 degrees Celsius, especially knowing that those come with some potential side effects for tolerating a lower temperature. The Hyperion trial maybe points in a different direction. We have 581 patients with non-shockable rhythms, mostly out-of-hospital cardiac arrests, 33 versus 37 degrees. And the intervention group, in this case, had more patients alive with a good neurologic performance scores, with a 4.5 absolute risk difference, with a 95% confidence interval reported there. You can see here, though, overall, very high mortality in this cohort, with the over 80% in both the control and the hypothermia group. Then over the last year, we were able to see the results of the TTM2 trial, which included the largest amount of patients by far to this point, 1,850 out of hospital cardiac arrest, 33 degrees Celsius versus normothermia with fever avoidance. I can't tell the story any better than this nice infographic slide does from the New England Journal, so I'll report those results here. You can see the relative risk for death or neurologic outcomes are very similar between the two groups, and the confidence intervals straddle one pretty significantly. And one thing that's really, really important to point out here is there's a 7% higher incidence of arrhythmia with hemodynamic compromise in the hypothermia group. As already mentioned, that significantly higher rate of arrhythmia causing hemodynamic instability. But on the other hand, there was no difference in pneumonia, sepsis, bleeding, or skin complications between the two groups, which may allay some of the prior fears of immune modulation or immunosuppression that might come with hypothermia. I'm intentionally giving you a 30,000 foot view of these trials because the time is limited today, and I think a lot of us have been exposed to them before. But here's a nice summary slide from a commentary that appeared in Critical Care that summarizes the main points of each article very nicely. And again, the QR code links you to the free open access article at Critical Care. So usually around this time we've presented these studies, and then we'll start to split hairs in terms of differences between who's receiving bystander CPR, what the control temperatures are, what the methods were to achieve the control temperatures, differences in survival rates across the studies, and then the location of cardiac arrest in terms of being in hospital or out of hospital. And this debate usually hinges on whether you think these studies are similar or different to the patients that you take care of. And that's totally defensible, right? Because external validity and generalizability is very important. That being said, there is no study that will show you that your patients are going to be different than the patients that we discussed today. There's just not going to be a study that defends that's at the level of rigor of evidence that you have here, where we have very large, well done randomized control trials with low risk of bias. There are some other studies out there that use other observational methods such as propensity score matching, but as we all know, those are fraught with their own limitations. Somewhat conveniently, a new meta-analysis, Bayesian meta-analysis and systematic review was published just this month, just in time for our debate. In this study, we have all the prior trials that we mentioned, plus a few others included here. And what's notable is here, first of all, in the A column is the mortality differences, and then the B column is the neurologic outcome differences. And you can see there's really no detectable difference between the two groups, maybe a slight favoring towards survival benefit in the targeted temperature management to 32 to 34 group, just based on the fact that the 95% credible interval is more on the below 1 than above 1, and the same is true for neurologic survival. However, when you take out the studies that did not actively manage the normothermia group to avoid fevers, and we're just then limited to TTM, Hyperion, and TTM2, you can see those differences, even though they weren't statistically significant to begin with, now are even less suggestive of a benefit to the more aggressive temperature management group. So where might studies go from here, and how can we better learn how to take care of patients after post-cardiac arrest? Do we compare normothermia to no TTM whatsoever, no fever avoidance, or things like that? This has been proposed. I'd be a little bit nervous about that, since I think some of the earlier benefits shown for targeted temperature management had to do with fever avoidance, and perhaps that's why we didn't see those differences in the later studies. Perhaps more interesting and more important would be to try to identify subphenotypes of patients which may respond differently to TTM strategies. And these will probably not be able to be identified by typical means such as initial rhythm or downtime or things like that, but there may be biomarker signals or clinical variable signals that we can identify that will help us decide if there are patients who are more likely to benefit. But right now, I think the burden of proof is on the person who wants to target the lower temperature. So in the meanwhile, are we done with TTM altogether? We have this pattern in critical care where we have a couple of positive studies to start with, and then subsequently it seems like nothing makes a difference, and then that introduces this intense feeling of nihilism where we feel like, well, I guess nothing matters. And I think that's part of the problem, and I think this is one place where proponents of TTM are in the right, and those who are in favor of abandoning temperature control altogether maybe have something to learn. It's important to consider the history of critical care medicine when we think about how care changes over time in response to even these small single-center studies which are highly biased. I can think of no better example than early goal-directed therapy in sepsis as a really nice parallel to this targeted temperature management story, because I think this explains a lot of how critical care proceeds and how we got to where we are. So we started with this Rivers trial in early goal-directed therapy, which really showed probably an implausible benefit. For more than a decade, we practiced early goal-directed therapy, and if you didn't, you were viewed as not doing the right thing. And then we had 3 multi-center studies across 3 continents, which showed us that these things maybe don't make a difference. And that engendered a sense of nihilism amongst some of us. Say, well, does anything that we do actually matter? Well, again, I think this is probably too simplistic. One problem with both of these approaches, the early goal-directed therapy approach and the aggressive lowering of temperature approaches, is these are really supraphysiologic targets. In early goal-directed therapy, we were targeting high CVPs, which is probably pathological, high central venous oxygen saturations, which may or may not correlate with oxygen supply-demand matching and may not correlate with adequacy of cardiac output, and then even transfusing patients to try to achieve these targets, which is in 2022 mind-boggling. Similarly, we're in the world of aggressive TTM, we're targeting very, very low temperatures, which introduce their own complications and their own secondary set of iatrogenic harms. Then we're talking about having to treat the side effects of our intervention. So we have to treat shivering, we have to introduce more sedatives, probably increase the duration of invasive mechanical ventilation. Both of these pathways introduce potential iatrogenic harm. So what is the benefit of this? Well, over the last 2 decades, we've seen how protocols can change environments of care. The first thing to consider, comparing studies done in 2002 versus 2021, 2022, there have been just general improvements in the way that care is provided in the ICU. Mechanical ventilation strategies have improved. The management of shock and sepsis has improved. The ABCDEF bundle, avoidance of iatrogenesis, removing lines earlier, not every patient getting a PA catheter, conservative transfusion targets, more liberal glucose control, while still realizing that glucose control is important. So then how do I think things like early goal-directed therapy may have positively impacted care? Well, it's made us all regard the fact that sepsis and septic shock is a medical emergency. And prompt resuscitations and antibiotics probably have changed the landscape of care over the past 10 years and makes the patients that Manny Rivers took care of probably different than those in the Process, Promise, and Arise trial and those that most of us take care of today. So there are things to be learned if we don't throw out the baby with the bathwater. Similarly, how does targeted temperature management positively impact care? There are many ways in which this is possible, and I think really what's most important is expectation management and goal setting. It makes you wonder what's more important, fever avoidance or feeling of futility avoidance. If you think your care plan offers some sort of promise, you're more likely to keep going and give the patient a chance to see if they can reach the point where they may establish neurologic recovery. If you throw all this out, then you're maybe leaving patients febrile and maybe you're withdrawing care prematurely. This is one of the neater and probably more practice-changing observational studies I've seen recently, and this was in CCM within the last year or two. QR code again is linked, but you can see the percentage of patients who will awaken stabilizes around 10 days out from rewarming. So up until that point, maybe by virtue of introducing TTM, you may be giving yourself the promise that you may reach that point. But if you're going to sort of prematurely deem that patients are neurologically devastated and don't have a chance to recover, you're going to miss a substantial proportion of patients who will awaken. So with that all said, what approach do I take now that I've been asked to take the con side of this debate? Well, I'll tell you that I've always kind of been a 36 person or 36 to 37 person, and fortunately TTM2 has reinforced that. If I walk into a patient who's already receiving targeted temperature management to 36, I'll probably keep it. If I'm the first person to contact the patient after cardiac arrest, I'll probably target normothermia, but do it in an active way. This doesn't mean that we're going to reactively ice pack the patient or start scheduled Tylenol or things like that, but really have active temperature management in place, but just not aiming for such aggressive targets. So in summary, if aggressive targeted temperature management is to be pursued, there needs to be a clear rationale based on specific patient factors, because at this point it's really not defensible to do this to all comers. We can say that fever avoidance seems more important than cooling for sure, and that absence of a targeted temperature management strategy at all is probably counterproductive. Nihilism has no place in post-arrest care. Just because less is usually more in the ICU doesn't mean that we should do nothing. Our actions need to be calculated and our patients need to be carefully observed. Thank you for listening today. I look forward to hearing the pro side of the debate and answering any questions in the Q&A session. If you have questions for me or you'd like to reach me, these are the places where you can find me. Thanks so much.